Okay. Good morning, one and all. So we shall start with the class with a brief review from what was taken yesterday. Could anyone just highlight on what was done yesterday? First, who will volunteer? Meanwhile, your friends will accompany you all. Still, they are coming. Yes. Could anyone just brief what has taken place yesterday? I mean, what was taught yesterday? See, people don't go and read also. Yesterday I told you all should go and write all the tubulo-glomerular feedback mechanisms, factors affecting GFR. Whenever there is increase in the arterial pressure and decrease in the arterial pressure or osmolarity. Fast because I need to discuss the case yesterday which I had given you all. Plasma clearance or measurement of GFR, right? We have charts on renal system which people will be answering for 5 marks in your practical exam. So during the chart discussion, which will be in one of the last class, so I'll take in detail about the plasma clearance. So I'm not going to deal with that today, right? So the next step in the urine formation will be tubular functions. Okay, right. So what was done yesterday? Any one student? Why are you taking so much of time? Yes. Yes, you just tell me the objectives. So one was the definition of the glomerular filtration rate, normal value. Second objective, very good. So the third objective will be, so I mean when you are answering also you can go according to this sequence when you are reading also. So it is factors determining filtration, which is dependent on the Starling forces, right, of filtration. Then, mind you all, Starling's law, the scientist Starling, right, Frank Starling, he has put up many works, right, related to various physiological functions, right. So, in the heart also, you people must have learned about it, right. So, here it is Starling's forces of filtration. Okay, then next. Factors regulating or affecting GFR. Okay, right? Is that clear? Fine. Okay. So we had a few questions regarding the efferent arteriole. In the end of the class, we'll discuss related to that. Okay. So first, I'll finish with the tubular function so that you'll get a sequence how the urine formation is taking place and how the sit down. Good. How the excretory products are being eliminated from the body. Okay. Right. I think one or two of you can come and sit in front here. Four students, in spite of we are having so many benches. Get inside. Those who are coming to my class, please don't wait for my permission. I don't want the class to be disturbed. Just come and sit. Okay? First of all, I told you all 5 minutes before the class, you people should be here. In spite of that, if you can't, just enter into the class. Okay, so the today's class is on tubular reabsorption and secretion, which are next two steps in the formation of urine. Okay, so before we start with this, why we need to learn about tubular reabsorption and secretion? Who will highlight on this? Filtration we need to know because it is helping as one of the method to assess the kidney function. Yes, right? So less filtration, less nephrons are functioning, and then we are going to treat according to that whether it is acute or chronic. Okay, right? Even though it is physiologically the first step in the urine formation, right? So overall coming to its application, why we need to learn about the glomerular filtration? Indirectly it is assessing the functioning of the kidney. So based on the rate, There are different stages how the chronic kidney diseases are classified. Okay, right. Now, why we need to learn about the reabsorption and secretion? In the first introduction class, I've told you all. Get inside. Why you need to know? See, just don't be passive listeners, right? Try to interact. You people have learned all this in your previous classes, especially those who are coming from CBSC. Yes? Good. Solute and solvents, both. Yes. Why you want them to get reabsorbed? What would happen if it was not reabsorbed? That is the main reason. No, you should know here now. Yes? Yes, very good. How it is maintained? Yes? Good. Sit down. Urea and creatinine. Okay. Yeah. Good. Okay. So indirectly, tubular reabsorption and secretion are going to retain all the solutes and solvents that are filtered. What type of filtration is taking place here in the kidney? Ultrafiltration, right? If whatever has been filtered to remove the waste products, if it was excreted in the urine, then none of us would have survived here. Yes? So, nature, I mean, our body systems are adapted to such an, I mean, the mechanisms are adapted in such a way, right? They try to restore whatever is needed to maintain the homeostasis. Okay? One part. What is the other part? Second important function. Why you need to know about the tubular reabsorption and secretion? Homeostasis, okay, it is a very generalized term. Now that was physiological part. Yes? Okay, so that is a part of homeostasis only, no? Yes? No, they are neither reabsorbed or secreted. That okay. There are certain substances which are used to measure the. I mean, she's talking about inulin. Just help me highlight on that. These substances are used for measuring the glomerular filtration rate. Okay, right? Another important function which I would like to know from you all. Many patients are taking drugs. Where are they metabolized? In the liver, and their byproducts are excreted in the urine, right? So to some extent they may be reabsorbed, and to some extent they may be excreted. So they need to be excreted through the renal tubules only, right? So there also the renal cells, the endoepithelial lining the renal tubular cells play a vital role. Okay, right? So this is the second component, right? So to understand the reabsorption and secretion of these renal functions, right? I've given you all a homework to find out the structure of the cells in the renal tubules: proximal loop of Henle, distal convoluted tubule, and collecting duct. Has anyone done that? No? Okay. Today you all go back and do, because that is very much important for the next class. Okay. So when we are giving some homework, like it will be related to some of the context of this next class or the same class. No, I mean the previous class. Okay. Right. When it is told in the previous class. Fine. So to understand this, I want you all to understand the transport across cell membrane. Okay. So in 2 minutes, we'll just revise what are the different transport mechanisms that are taking place in our body. Yes. And what are the requirements for diffusion of the substances in a tissue or a cell? Who will tell this? Why are you all so silent? Yes? Yes, very good. So the broad classification is active and passive, right? So in passive, it is moving from higher to lower. Why I'm telling this is at different points in the renal tubules, right? It is going to be passive transport. At certain points, it is at the certain level of the renal tubule, it is going to be active transport. And we are going to learn one more term, transcellular or transepithelial is the word used there commonly. What do you mean by transepithelial? Yes, from one epithelium to the basal other epithelium, then it's going to the blood. Otherwise, normally what's happening? From the blood, it is going to the cells, and from the cells, it is going to the blood. Isn't it? Right? Fine. Then, what do you mean by secondary active transport? These all mechanisms are involved here now. So, in one picture, I'm going to explain you all the functions. But basics you all should know here now. What are the other transport mechanisms? Yes, last benches, are you all with me? Yes? What is secondary active transport? Wait. Anybody here? You've done this in January. Roll number 45. Okay. So, the first movement is along the concentration gradient, right? But at the other level, it is going to be transmitted by the active transport. Okay. This is seen in the distal convoluted tubule for sodium reabsorption, secondary active transport. Okay. Right? Fine. Then, what is endocytosis? Exocytosis? Yes. Endo is taking the substances inside the cell, and exocytosis is expulsion of the substances. What is a good example for exocytosis? Most of the hormones, isn't it? Most of the hormones which are synthesized are released by exocytosis. Acetylcholine at the neuromuscular junction. Yes? Okay. Right? So with this brief introduction, because it is with these transport mechanisms, I think this kidney tubule, nephron, it will be a very good example for you all to give or answer when you are asked a question on transport. Classify transport across cell membrane and elaborate two examples with two examples. Okay? So all the parts of this nephron you can give as an example for both primary, secondary, facilitated, all types of transport mechanism. Exocytosis, endocytosis. Is that clear? Okay? Right. Fine. So now coming to the objectives. So transport across different segments of the renal tubule, then handling of the solutes and solvents. Then two terms you are going to learn here is what is renal threshold and what is tubular maximum. Okay? When we say renal threshold, concentration of any substance that is being reabsorbed from the renal tubules, and we are going to determine it at the plasma level. For example, what is the renal threshold for glucose? What is the threshold for sodium? Right? Okay. The second term what you are going to learn here is tubular maximum. That means concentration of any of this substance that is being filtered to the tubules. Okay? How much is it? It is not reabsorbed. What is the load presented to the renal tubules? Again, I am taking an example of the glucose only. Tubular maximum for glucose is 375 milligram per 100 ml. The load. Okay? Right? So, if the blood glucose is more than this, right, more glucose will be excreted in the urine, glycosuria. Are you getting the difference? Threshold is the plasma level. Okay? Right? Whereas, that means maximum our reabsorption is going to take place to that level. Similarly, we are going to have tubular maximum for sodium, chloride, ions and solutes, both. A good example you need to know here is for glucose, because diabetes is common and most of you all must have read it also. Okay? Right. So now, this is the diagram, right? So with the help of this diagram, I'll just try to explain what are the substances that are being filtered. So what you people do now, take 2 minutes, right? And write down all the concentration of the substances that is present intracellular and extracellular. Fast. So that who all are sleeping, they'll wake up. What are the substances present in the intracellular fluid and the extracellular fluid? These are the substances. I mean, solutes and solvents will be the better term to use here, right? So, I want you all to write down, just to wake you all up, right? What are the substances that are present intracellular and extracellular? If you go back to see our body fluids, how are they classified? Intracellular and extracellular. We are having 42 liters of fluid, right? Intracellular is how much? 28. Extracellular is 14, right? All of you have forgot it, right? Very good. Fast. What are the substances present? If you want, you can refer your books, your mobiles. No issues. But some activity has to be done from your side. I don't want you all to be just mere listeners. What are the substances that are present? So almost all is there in this diagram, but still I want you all to separate them now. Which ions are present intracellular? Which ions are present extracellular? That is inorganic. Coming to the solutes, we are having glucose, amino acid, urea, creatinine, right? Where are they present? Intracellular or extracellular? We have got proteins. In RBC, we are having hemoglobin. Fast. Finished? Who is 103? Roll number. Yes. Can you answer this question? Please mask. You are not audible. Okay. Listen here, all of you. And what you have written, please check it. This is a revision now. What has been done in January, February. Very good. And sulfates. Yes? Okay? So we have got sodium. Very good. Sit down. Have you all written this? Is it clear? Right? So we have got, why I'm asking you all to know this is, so potassium is more in the renal tubule cells that are lining the renal tubules here. Okay? So this is the cell lining here, right? But whatever is filtered is the plasma. Plasma is extracellular or intracellular fluid? Extracellular, right? So potassium is also there in the extracellular fluid. It is there, but very less concentration, right? So to some extent, potassium is filtered here. Okay? So which are the ions that are filtered more here now in the plasma? We are going to have 99% water. Yes? Sodium, chloride, bicarbonates. Right? What are the solutes that are present in the plasma? Glucose, amino acids, creatinine, and urea. If the patient is on any treatment, the byproducts of the drugs could also be here. Yes? Do you all agree with this? Right? Fine. So now what all substances need to be reabsorbed here now? Do we want all the sodium that is filtered to be excreted? No. Right? So 75% of the sodium is reabsorbed in the proximal convoluted tubule that is filtered. Okay? Right? Similarly, in the proximal convoluted tubule, the epithelial cells that are lining, they are going to reabsorb all these substances. These are the filtered substances. Right? In the range of 60 to 70%, all these substances are reabsorbed by what mechanism? Passive diffusion. So there is no active transport seen in the proximal convoluted tubule. Okay? Right? Is that clear? So most of these are reabsorbed by the passive diffusion. But now when it comes to the passive diffusion, we are having again facilitated diffusion. Yes? So it could be symport or uniport or antiport. Isn't it? Right? Usually sodium is reabsorbed by what mechanism in the body? Is sodium alone reabsorbed or it is absorbed along with some other substance? With glucose. Isn't it? In the intestine you people must have learned. So always sodium and glucose are also reabsorbed here. Then most of the bicarbonate that is filtered here is reabsorbed again, right? But at the same time in the renal tubular cells, some bicarbonate is synthesized. Do you all agree with that? Yes? Right? So that synthesized bicarbonate comes into play in the place of renal acidosis, balancing renal acidosis and alkalosis. Okay? So whatever bicarbonate is filtered here from the plasma that is present, as she said, which is present in the extracellular fluid, that is reabsorbed. Okay? Right? Then coming to glucose, 100% of the glucose is reabsorbed. Okay? So when you are mentioning the tubular functions, you all should know what concentration of these substances are being reabsorbed at the proximal convoluted tubule, and as the filtrate moves downwards along the loop of Henle and reaches the distal convoluted tubule. So if you see here, some substances are reabsorbed here. What is that? Again sodium chloride, water, right? And then we are having to some extent urea. Okay, right? And some part of the urea is again reabsorbed in the collecting tubule under the influence of the ADH. Okay, ADH is going to help in reabsorption of water. So this in detail you will be learning about in the concentration and dilution of the urine. That is the next class which will be taken by Dr. Anita madam. Okay, right? So now, if you see the tubular, right, as this filtrate, so is this clear now? Right? So all the substances that are being filtered here in the range of 60 to 70%, it is reabsorbed in the proximal convoluted tubule, right, by maximum concentration gradient. The cell is having more or the filtrate is having more here in the tubules, substances in the filtrate. So it has to move along the concentration gradient. All of you agree to this? Yes? Fine. Good. Then comes the filtrate. So whatever 25% is remaining here, it moves downwards. So this membrane, that is the thin loop of descending loop of Henle, right, is more permeable to water. So another 10 to 15% of the water, or almost 10% of the water, is being reabsorbed here. So this reabsorption of the water is important again in maintaining the fluid volume. Okay, so this membrane is permeable to water, but the ascending limb of loop of Henle is impermeable to water, but permeable to sodium, potassium chloride ion channels. Okay, right? So sodium is reabsorbed, potassium is secreted, whereas chloride is also reabsorbed. So this again, the channels and their significance is in the concentration and dilution of urine. But you all should know which channels are present in which part of the renal tubule. Okay, right? Fine. So now when it comes to distal convoluted tubule, what percentage of sodium is remaining here now? 75 is reabsorbed here. Right? Then 25% we are having here. So 15 to 20% of the sodium is reabsorbed in the distal convoluted tubule along with the water. Always there is a solvent drag. Okay, right? But this part of reabsorption of the sodium is dependent on aldosterone. Okay, so two terms you people will be using here now. What is facultative, right, and what is obligatory? So this will be a homework for you all because this is required in the concentration and dilution part. Okay, right? So today I am just dealing with the substances and the channels that are involved in the reabsorption, secretion or excretion in case of the different parts of the tubules. Is that clear? Right? Now what happens? The remaining 10% of the water, right, as well as the urea 50%, because only 50% of the urea and creatinine are reabsorbed here. Rest all is going to get excreted. Okay? Some part of the urea is going to get reabsorbed in the collecting duct, right, here, because it has to maintain the osmotic gradient in the medulla for conserving water. Again, you will be learning this in the next class. Okay? Right? Fine. So, is this clear now? What all substances are filtered? That is the reason I made you all to write what are the substances present in the intracellular and extracellular fluid. Right? So, potassium is more in the filtrate or in the renal epithelial cells now. Renal epithelial cells. So, potassium has to be secreted or reabsorbed. It has to be secreted. Yes, isn't it? Right? Again, it depends upon the H ions or the channels which are going to get exchanged. Okay? Right? For the specific functions. So, that is the reason why I asked you all to know about the characteristic features of the proximal convoluted tubule. Okay? Then coming to the reabsorption of the sodium. So, here we are going to have what type of fluid that if filtrate enters? Is it isotonic, isoosmotic? The filtrate is hypo, iso or hyper? Yes? Hyper. Okay, one student is saying hyper. Who is How many of you agree with this? With him? Okay, fine, good. Any other students? Can you explain me why it is hyper? Whatever filtrate is coming to the renal tubule. Yeah, sodium is maintaining osmolarity, no? Right? Whatever sodium is there in the plasma is filtered. So whatever the filtrate is reaching the proximal convoluted tubule, then why it should be hyper? Hmm? So it has to be iso, no? Whatever filtrate is reaching the proximal convoluted tubule, right, is it isotonic or hypertonic or hypotonic? Yes, in relation to ECF, what is being filtered. Hmm. Is isoosmotic. Yes, sit down. Right? So whatever filtrate is reaching the renal tubules, right, it has to be iso. Because why I'm telling this is because as this fluid moves along the distal convoluted tubule, it becomes hypotonic because water is going to get reabsorbed. Okay, right? So you all are confused a bit. Yes? Yeah, that's what. See, I'm just highlighting these all points because this will come to you in context to the next class. Okay? So I'm just giving you all a hint so that you people don't get confused. Anyway, first let me finish this, then I'll come to the load. Okay? Right? But please remember that whatever filtrate is reaching the proximal convoluted tubule is isotonic with the plasma. It is not hyper or hypo. Right? You will learn this in the concentration and dilution part. Okay? Right? Yes. So when it comes to the sodium reabsorption, sometimes they'll ask you a question on role of kidney in sodium handling. Okay? So that time the different mechanisms by which the sodium is reabsorbed at the different levels of the proximal convoluted tubule has to be answered. Right? So what are the key points here now? First, so whatever filtrate, it is reaching the proximal convoluted tubule. Okay, let me come back to this diagram. All sodium is filtered here from the plasma. Yes. So in the proximal convoluted tubule, by what mechanism sodium is reabsorbed? By passive diffusion. Right? And it is facilitated because it is reabsorbed with glucose. Right? First part. Right. When this sodium reaches, any sodium is reabsorbed here in the loop of Henle? No. Right? More water, it comes in the distal convoluted tubule and the thick ascending limb of loop of Henle. It is not in the main tip of the loop of Henle. Right? Most of the sodium is going to get remaining in reabsorbed in the distal convoluted tubule. See, is there any sodium here? Right? It comes in the thick ascending loop of Henle because there are sodium, chloride, potassium channels here. Okay? Then we are having here sodium channels which is dependent on the aldosterone in the distal convoluted tubule. Right? So renal handling of sodium, when is the question asked, instead of asking sodium reabsorption, so here you have to mention just not at the sites but what are the different mechanisms involved in reabsorption of sodium. So I am giving example for sodium. Later on you have to answer for all the ions like this. How bicarbonate is reabsorbed, how chloride is reabsorbed. Okay? So all that mechanism I'm not going to take in this class now. Is that clear? Right? Then here in the distal convoluted tubule, we are going to have reabsorption under the influence of aldosterone. Aldosterone, if you learned the mechanism in the endocrine already done, what do the aldosterone do? What is the role of aldosterone in sodium reabsorption? Yes? How? Yes? Aquaporesis for water. What is the role of aldosterone? What does it do? This is what you have to answer. It helps in the production of protein channels for reabsorption. Okay, not aquaporins. Ion channels for sodium reabsorptions, and that is going to help in reabsorption of more sodium, right? Once sodium is reabsorbed, then how it is going to diffuse back to the plasma? By what mechanism? Yes. So from the tubule here, whatever sodium is reaching here, under the influence of aldosterone, it is going to get reabsorbed in the renal tubules, epithelial cells, right? At the basal layer of the renal epithelial cell, we are having sodium ATPase. Okay, right? And along with the sodium activation of the sodium ATPase enzyme, the remaining sodium enters the blood. Okay, in the peritubular capillaries. So initially it is passive, then at the basal level it is secondary active transport. Okay, anyway, I'll come to that. Similarly, we are going to have, see here now, we are going to have here potassium ion channels, right? So how potassium ion channels are reabsorbed? Again, whatever is filtered, right, it is not more than 40 to 50. If you go to see the concentration of the potassium in the extracellular fluid, right? So whatever is filtered, with the help of these potassium ion channels, it is going to be absorbed by the renal epithelial cells. Then from the basal layer of the renal epithelial cells, it is going to reach the blood, which is lining along the peritubular capillaries. Okay, right? So like this, various transport channels need to be explained, because some are going to be transported by uniport, symport and antiport. So for what substances, what is the mechanism involved has to be learned or answered in your paper, not just reabsorption by the renal tubules. If you are, this could be asked for 10 marks question, tubular functions. So that time you have to answer how sodium is reabsorbed, water is reabsorbed, potassium, chloride, bicarbonates, urea, glucose, amino acids. Amino acids and glucose role is not much, because all whatever is being filtered is reabsorbed in the proximal convoluted tube. Okay? So what is important for us here is, go back to the functions of the kidney. One is maintaining blood volume. What is required for maintaining blood volume? We need sodium. Any change in the sodium concentration is going to affect the blood volume along with the water. Yes? Disturbance in the sodium. Okay, fine. If there are increased H ions, a patient is suffering from diabetes, metabolic acidosis. So H ions are produced more. What is the role of the kidney in removing these excessive H ions? Will be the answer. Okay? Right? So for removal of the H ions, usually we are having hydrogen potassium ion channels. Okay? So potassium is reabsorbed, but H ions are secreted, because more H ions need to be removed from the body. Are you all getting it? I hope I'm not confusing you all. Right? In broad, I'm just telling you all, there are different ion channels which are lining along the tubular epithelial cells. So here we are having two components, right? So one is the tubular lumen. Just pay attention to this, right? So whatever is being filtered here is going to get reabsorbed depending upon the concentration gradient. Okay? If we want some substances to be secreted, for example, I'm telling you all potassium hydrogen ions. Okay? If there are more hydrogen ions and if the kidney needs to eliminate more hydrogen ions, so that time it is exchanged for potassium hydrogen ions. Okay? Right? So, for all these substances which are present in the filtrate, which are going to be reabsorbed by the renal epithelial cells, this is at the luminar level, we are having epithelial cells, and we are having epithelial cell at the basal level also. Are you all getting it? Right? So all these substances which are going to be filtered, they are first going to enter into the renal epithelial cells. A good example here now, potassium handling, right? So we have got potassium channels at the tubular luminar cells as well as at the basal layer. From the basal, it will go to the interstitial space, and from the interstitium, it is going to enter into the peritubular capillaries lining the nephron. And that is going to reach the venous end. Again, from the venous, it is going to the heart. Is that clear? Transport mechanism, right? So, in your self-directed learning, if this topic will be put up, then that time you people are going to prepare some charts or a concept map like I'm giving an example like what are the alternative methods you can use for this type of learning here. Right? So here you can have sodium, potassium, where sodium is reabsorbed, where potassium is reabsorbed, where are the H ions secreted or excreted, right? Because H ions are initially secreted, later on they are excreted in the urine. Are you all getting it? Right? So the homework for you people will be, you have to go back and for each substances that are being filtered by the plasma have to be reabsorbed to restore homeostasis. Okay? So what are the different mechanisms involved in reabsorption of all these substances? As I have given you an example for sodium, right? What is the mechanism of reabsorption of sodium in the proximal convoluted tubule? What is the mechanism of reabsorption of sodium in the distal convoluted tubule and the thick ascending limb of loop of Henle? You have to mention in detail. Similarly, it will be for bicarbonate, it will be for chloride ion channels, it is going to be for glucose, amino acids, right? So here again, what type of transport is involved here? You have to mention at each level. Is this clear? Right? All these substances, you know what are present intracellular and extracellular, and whatever is filtered has to go back to the plasma, and what are the mechanisms involved has to be described there. Okay? I don't think so we need much of teaching here, but it is understanding the concepts. Is that okay? Right? Okay. Similarly, we are having water reabsorption. 75% of the water is reabsorbed in the proximal convoluted tubule. Remaining 15 to 20% is reabsorbed under the influence of ADH. Right? So this part, this is the basics what I am giving you all. So this application will be for your next class. That is on maintaining the fluid volume. Are you all getting it? So whatever I have told now are the questions that will be asked by Anita madam tomorrow when she is dealing with that class. That is on Thursday. Right? Yes. So I told you all to find out these cells. You all should know what is the role of the principal cells, right? And what is the role of the intercalated cells. So principal cells, mainly reabsorption of sodium, and that is the reason in the first class itself I told you all. You all should know the anatomy of the epithelial cells and what are the different types of cells that are going to help in reabsorption of different substances. But none of you all have done the homework. Okay? Fine. So you can use this diagram. Here, when you are answering, right? So just even if you don't give your theory part also, I've come up these with these pictures because in the exam, even if you draw this type of diagram also, but you have to give the content in detail. See here, for example, now if you take proximal convoluted tubule, all the plasma that is being filtered here, right? It has sodium, potassium, bicarbonate, and all are reabsorbed here. Which are the solutes that are reabsorbed? You have to mention the concentration. So once you answer this, there is again no need for you all to write the essay part. Right? So many of you all don't waste time. So you can answer your questions with the diagrams, but the content has to be elaborated in context to that part of the diagram. Are you all getting it? Right? So this will save a lot of your time, and this diagram will give you the picture to the evaluator whether you know the answer or no. Okay? Because your essay questions, grammar will be very poor, right? And main content of the answer may not be highlighted when you're writing it in. So try to answer maximum with the help of diagrams. Okay? Right? But your content has to be elaborated here. That is the reason why I've come up with this diagram. Similarly here, see here now, sodium is reabsorbed with the help of sodium channels. Water will be reabsorbed in the collecting tubule with the help of ADH or vasopressin receptors, which are going to help in formation of more aquaporins and more reabsorption of water along the collecting duct and distal convoluted. Okay? Right? Okay. The second part is another 5 minutes I'll take you all just to explain. So you can answer it like this also. What substances are moving out and what substances are being secreted or excreted. Okay. So what is important for us here is, I told you all about the two terminologies, threshold and tubular maximum, right? So this is for the glucose reabsorption now, along with the sodium. So we are having here, I hope you in the GITU people have learned. So if you are asked on what is the mechanism of glucose reabsorption or renal handling for glucose, or what is the role of kidney in glucose reabsorption, okay? So that time in the proximal convoluted tubule, 99%, right? Or you can say 100% of all the glucose amino acids are reabsorbed here, and 50% of the urea. Okay? But when it comes to your molecular level, what we expect from a MBBS student, right? So if it is for a allied courses and all, where we are taking only the, depending upon the curriculum, where the superficial part is taught, so that time we don't expect them to answer at this molecular level. But you people, when you're answering for a 10 marks question or a 5 marks question, just reabsorption of the proximal convoluted tubule, you'll be getting only half marks. Always when you're answering, your content should be at the molecular level. What are the basic mechanisms involved there? Okay? Right? So when it comes to sodium and glucose reabsorption, again sodium, it will be concentration. As I told you all, it is a symport. So it is absorbed with the help of the receptors. There are two types of receptors here. T1, T2, we are having again 5 here for glucose reabsorptions. Okay? So T2 is present here in the renal tubule. Okay? Similarly, we are going to have it at the basal level, basolateral, and from here it is going to come to the renal epithelial cells. From the renal epithelial cells, it is going to go to the peritubular capillary. So this has to be explained in detail when you are answering for any tubular functions, whether it is handling of sodium, glucose, chloride, bicarbonates. Bicarbonates role come in case of acid-base balance. Okay? It is same. So one term which you all should know here is a splay. What is splay here? Okay? Whatever glucose is being reabsorbed, so the maximum glucose that can be reabsorbed by the renal tubule cells is 375 milligram. Okay? Right? When it excretes more than 375, that time it is going to be excreted in the urine as glycosuria. But here what happens, what do you mean by tubular maximum? If this 375 load is observed, I mean maximum up to 375 the glucose is reabsorbed, right? But when we are going to see whatever is filtered, we should get a straight line. But here what happens, we are going to get a curve here. This is called the splay. You are having this chart for your exam. Okay? So what is splay? In handling the glucose by the renal tubules or tubular splay, that is because all the glucose that is being filtered is not at the same time by the nephrons. So different nephrons are going to filter at different levels the glucose. Okay, right? Reabsorption of the glucose and once it is filtered. That is the reason why we are not going to get a straight line that is being filtered and excreted, but we are going to get a curve here which is called as a splay, right? And the remaining part, all the as I told you all, in a normal physiological person, all per 100% of the glucose that is being filtered by the plasma is going to get reabsorbed. So once this load goes beyond 180 in the plasma or 375 in the renal tubular fluid, that time it is going to get excreted in the urine. Is it clear? So they'll ask you all why all the filtered glucose is not being reabsorbed at a one stretch. That is because different